Good morning, everyone, and welcome for coming. Thank you for coming to the September 2022 in-service on small intestinal bacterial overgrowth brought to you by Non. And I am going to turn it over to him. As a reminder, if you do not have handouts, please feel free to message me in chat and type your email address or send me an actual email, and I will happily send you the handouts for today to accompany the handout. Otherwise, I'm going to turn it over to Nan, and please remember everybody to mute yourself if you can. Nan, it is all you.
All right. So hello, my name is Nan Tran, and today I'll be talking to you guys about SIBO. So SIBO stands for small intestinal bacterial overgrowth. And for the rest of the talk, I'll be referring to that as SIBO. So the objectives for this talk is that you guys will be able to explore how SIBO affects other disease states, understand the symptoms of SIBO, and identify pharmacologic and non-pharmacologic treatment options for SIBO. So SIBO can be defined as an abnormal bacterial population in the small intestine exceeding 10 to the 5th to 10 to the 6th organisms. Normally, there are less than 10 to the 3rd organisms in this upper small intestine. So the small intestine is where most of the food absorption takes place in your digestive tract, and it's made up of 3 parts: the duodenum, the jejunum, and the ileum. So you see there on the PowerPoint, the colorful middle part, that is where the small intestine is. So your small intestine functions to absorb nutrients like vitamins, minerals, carbohydrates, fats, and proteins, as well as water from food so that they can be used by the body. And the type of bacteria in your body makes a difference on how well your body absorbs nutrients. Too much of one type of bacteria or overgrowth of bacteria that is not normally there may lead to GI problems or gastrointestinal or digestive problems, as you can say it. And we'll get more into that a bit later. So some risk factors that may predispose someone to developing SIBO can be structural abnormalities of the GI tract. So the main structural abnormalities coming from surgery or bypass a part of the GI tract. And this can cause something called blind loops, where bacteria can grow because there's not a constant flow going through that part of the GI tract. Other risk factors are motility disorders, where the flow of your digestive system is being blocked or disrupted. And you can see examples of that in disease states such as gastroparesis, small bowel dysmotility, celiac disease, or chronic intestinal pseudo-obstruction. And going back to gastroparesis, this disorder can actually present in 2 different ways. Either it causes everything to run right through your digestive system, or it can cause a huge blockage. And for the purpose of the SIBO discussion, it's the latter that can increase the risk of SIBO. And the reason why motility disorders can increase the risk of developing SIBO is because these disorders slow the flow of your digestive system, which allows bacteria to grow. Irritable bowel syndrome, or IBS, can also slow down your digestive system, typically called small bowel dysmotility. In patients diagnosed with SIBO, a large portion of them already have shown to have IBS beforehand as well. Then moving on to metabolic disorders, diabetes is a well-known disease state, and when uncontrolled, it can also predispose someone to developing SIBO, especially when you're older, and we'll get into why that is in a bit. Another metabolic disorder is hypochlorhydria, and this condition is marked by low levels of stomach acid, which you use to help digest your food. So if you don't have enough stomach acid, you can get digestive problems, a lack of nutrients, and bacterial infections, ultimately leading to SIBO. So more risk factors of SIBO include organ system dysfunctions such as liver damage, kidney failure, pancreatitis, Crohn's disease or the inflammation of small intestines, and celiac disease, malnutrition, and immunodeficiency states. Medications can also contribute to the development of SIBO. those could be recurrent or the overuse of antibiotics. And this goes for any antibiotic that are used to treat bacteria in the gut. So the chronic use of antibiotics can cause the bacteria to become resistant, which makes conditions like SIBO or any other infections harder to treat. Medications that reduce the gastric acid or the stomach acids can also contribute to SIBO because it works to lower the number of bacteria in the gut as well as digest foods. And then lastly, just being old can also increase the risk of SIBO. And then I'm going to stay on this slide, but in the handout, I'm moving into the section called populations at risk, where I'm going to elaborate more about the different disease states that can contribute to SIBO. And so again, age, as you get older, your gut motility tends to slow down, which gives bacteria the opportunity to multiply in your small intestines. Older patients also tend to be on more medications that can slow the GI tract as well. Then again, IBS, as you said before, can slow down the flow of your digestive system, which I've already stated. It's an opportunity for bacteria to multiply in that condition. And many studies have shown that there's a correlation between IBS and SIBO. They found that there are a large percentage of IBS patients tested positive for having abnormal lactose breath tests, which is one of the main tests to diagnose SIBO. Furthermore, symptoms of SIBO and IBS are very similar. IBS patients typically have decreased gut motility, delayed transit, or abnormality in the MMC, or the migrating motor complex, which is a complex that helps push the food through the small intestine. But an abnormality in these functions can predispose patients to developing SIBO. SIBO can also increase fecal calprotectin levels, which is a marker for inflammation in the colon, making it harder to differentiate SIBO from IBS. And for metabolic disorders such as chronic and poorly controlled diabetes, it could lead to bad GI motility. Being hyperglycemic decreases motility and actually causes slow small intestinal function, increasing the severity of the diabetes and SIBO. Gastroparesis and neuropathic small bowel motility disorders are both associated with increased risk of SIBO as well, just because it slows down the GI tract. And then going back to organ system disorders, specifically celiac disease, it's assumed that celiac disease and SIBO can affect each other because in celiac disease, eating gluten damages the small intestine, causing it to slow down and increases the risk of developing SIBO. So both disease states presents in some form of decreased gut motility. Hence, having both disease states can actually cause like perpetual harm. And then another disease state I didn't talk about yet that has a high risk of developing SIBO is hepatic encephalopathy or severe liver disease. And when you have severe liver disease, it's common for you to have an altered GI microflora meaning the normal bacteria in your gut. So these microflora may include a species called alkaligenaceae, which produces urea and prevents it from being degraded or broken down in the bowel. So the urea goes into the patient's systemic circulation, which contributes to the increasing levels of ammonia in the blood, leading to worsening liver damage. So now going back to SIBO, let's talk about the symptoms of SIBO. So you can see abdominal pain or discomfort, bloating, abdominal distension, which is just swelling of the abdomen, diarrhea, flatulence, or overall weakness. And this is very important to understand that all these symptoms can be very similar to other diseases as well, especially IBS. So the clinical complications of SIBO can range from mild to severe, mild being diarrhea, vitamin deficiencies, and an unintentional weight loss, going all the way to severe being malabsorption to neuropathy, which is just damages to your nerve system. I'm going to focus on two of the main complications, vitamin deficiencies and malabsorption. So for vitamin deficiencies, with SIBO causing low gut motility, there's a lack of vitamin absorption. Typically, there are no symptoms, but in rare cases, patients can develop symptoms such as night blindness from vitamin A, osteomalacia, or soft bones from hypoglycemia or a lack of vitamin D, prolonged prothrombin time or a lack of vitamin K. They can also develop neuropathy or retinopathy, which is damage to the eyes. And then a super important vitamin that you don't want to be deficient in is cobalamin or vitamin B12. So vitamin B12 in the body helps to develop red blood cells and DNA, which is also very important for elderly patients to have. It is highly bound to the proteins in our food. And in SIBO, there's a lack of nutrient absorption because of the increased number of bacteria. So if the protein is being prematurely taken up by bacteria, there won't be enough B12 in the body. And supplements in this case can help. However, as you get older, the less vitamin B you'll be able to absorb from supplements because your body tends to have problems with the enzymes and the acids needed to process vitamin B12. And then continuing with malabsorption in SIBO, there's a lack of nutrient absorption from fats, proteins, and carbohydrates. For fats, bacteria in the intestine deconjugates or breaks down bile salts, which are needed to break down and absorb fats. And those bile salts are actually being absorbed in the jejunum instead of lower on in the GI tract where it's supposed to work. And so what this does is it decreases motility and leads to malabsorption of fats, which can present as steatorrhea, a condition where our fat will actually be excreted in your poop, causing your poop to float. And then for protein, the overgrowth of bacteria prevents the body from absorbing proteins, which can lead to unintentional weight loss. It can also prevent certain drugs from working properly because certain drugs are bound to protein, and then only the free drug can have its effect. But if there's an excess of protein in the gut because of the malabsorption, there's going to be less of that drug available because they're all going to be bound to those proteins. And for carbohydrates, the bacteria in the small intestine will prematurely break down carbohydrates and use it for themselves before it can be absorbed by the body. And that's how most of the other malabsorption occurs as well, because of the increased number of bacteria will basically eat the nutrients before your body can absorb it. Alcohol is also a form of carbohydrate that also has a negative impact and further feeds the bacteria. So some medications we have talked about before can contribute to the development of SIBO, especially medications that slow gut motility or decrease stomach acids, which we said before were also risk factors for SIBO. Common drugs that slow gut motility are narcotics. These drugs are mainly used to treat pain in patients, and one of the many side effects of narcotics is constipation. So narcotics over time slows the GI tract, leading to constipation. However, this predisposes the GI tract to develop SIBO since gut motility is decreased. Then drugs that decrease stomach acid secretions are PPIs or proton pump inhibitors, and those are listed below as well. And these drugs are mainly used to help a patient who have GERD. And the reason why PPIs contribute to the development of SIBO is that the PPIs lower the acid content in the GI tract, which allows bacteria to move from the stomach to the intestines, causing growth of abnormal bacteria in the small intestine. So now that we've talked about SIBO and how other disease states can affect it and vice versa, let's talk about how you diagnose SIBO and how to treat it. So there's two main ways of diagnosing SIBO. The first of which is getting bacterial cultures. They do this by collecting anaerobic and aerobic colony counts in the small bowel lumen. And we don't do this often because we must pass a catheter into the duodenum through an endoscope, which is expensive and very painful. It's hard to grow intestinal bacteria. And then the act of retrieving bacteria can contaminate the results with other species. And the second way, and the most common way we diagnose SIBO, is through breath tests. And there's two kinds of breath tests, glucose and lactose. What happens is that they give you a certain amount of glucose or lactose, or a form of that to consume. And when the bacteria breaks it down, a certain gas is released, and they're measured to see if you have SIBO or not. For the lactose test, carbohydrates that are most readily metabolized are lactose, glucose, sucrose, or xylose. And then for the glucose test, they use xylose or glycolic acid. And the substrates for what you consume are those are the substrates that you use to consume for the test. And so the gases that the test measures are mainly hydrogen and or methane. And you're considered positive for SIBO if there's an increase of 10 to 12 parts per million from baseline during the first 90 minutes of the test. And a second acceptable diagnosis, there are double peaks of the hydrogen. And as you can see in the graphs below, if you're looking at the handout, there's like 3 graphs below. The one on the left shows a baseline of hydrogen in the body when you expel air. And the middle one shows a positive result. And you can see how the graph is going a lot higher with hydrogen. And then the one to the far right has the double peak. And so for treatment, the goals of treatment are correcting the underlying cause, providing nutritional support, and treat the overgrowth. So to treat underlying causes, patients with gastroparesis or small bowel dystrophy may find improvement with prokinetic agents, which is a class of drugs that are used to increase gut motility. For example, prucalopride, which helps with gut motility for chronic constipation. Some herbals can also help improve gut motility, like curcumin, peppermint oil, ginger, and probiotics. However, with probiotics, you have to get them in an active state. For example, yogurt that is flavorless will have active probiotics. Yogurt with added sugars and flavorings will have bacterial cultures. However, they're in a static state and they won't multiply and add to the good bacteria in your gut. And then patients with cirrhosis or liver damage, SIBO, and small bowel disease will typically see an alternating therapy of neomycin or norfloxacin, both of which are antibiotics, and neomycin is mainly used for patients with methane-dominant SIBO. And so moving on to nutritional support, it's also super important, and we've already talked about how SIBO can already impair the absorption of nutrients and vitamins, so it's suggested to supplement them. For vitamin B, as we said, when you get older, it gets harder to absorb it orally. So there are injections that you can take that will be more absorbed in the body, but you need a doctor prescription and a doctor to do it for you. And for treating the actual overgrowth of bacteria, antibiotics are the main way to do it right now. Ideally, using bacterial cultures and sensitivity data is the best, but getting cultures, as we have already discussed, comes with a lot of problems. So originally, tetracyclines were first line. However, recent studies have shown that rifaximin was better at improving the breath test. And you may see it as Xifaxan, which is the brand name of rifaximin, 550 milligrams 3 times a day for 10 to 14 days, and is shown to be 56 to 60% effective at improving those breath tests. Other broad spectrum antibiotics that can be used are augmentin, ciprofloxacin, and doxycycline. And then so studies have shown that patients with Crohn's disease or a blind loop, metronidazole was actually better than rifaximin in those patients. Studies have also shown that metronidazole has similar efficacy or has similar improvement like ciprofloxacin for the treatment of SIBO and Crohn's disease. Other studies have shown that the use of norfloxacin has similar efficacy to augmentin for the treatment of SIBO, and that a 10-day course of neomycin only improves symptoms and not necessarily the lactose hydrogen breath test. And then studies have also showed that rifaximin greatly improved the symptoms of bloating as well specifically. And then There are currently no other pharmacologic treatments for SIBO that are long-term, since the current mainstay is antibiotics. However, diet is essential for decreasing SIBO symptoms as well. So you want to decrease or avoid complex carbohydrates that are hard to digest. So avoiding FODMAPs containing foods can greatly improve symptoms. And so what FODMAP stands for is fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these are considered to be short-chain carbohydrates that the small intestine absorbs poorly. So the FODMAPs diet is actually very similar to typical diabetic diets, where you would want to avoid eating foods with complex sugars and carbohydrates like apples and onions. And so these pictures are here for you to see for yourself some examples of high FODMAP foods and which ones are better to swap out with. And there are certain FODMAP groups that will worsen SIBO depending on the person. Everyone has different things that trigger and exacerbate their SIBO. And a good way to figure that out, which foods are troublesome, is just to avoid all FODMAP foods and then slowly introduce them in your diet one at a time to figure out which foods are the main triggers. It is recommended to reintroduce foods every 3 days, one at a time. So overall, SIBO is still a relatively under-researched disease state and has a lot of mixed results. Many of the studies are smaller studies and have not been backed up or have had larger studies shown similar results. So further studies are needed to find safe and effective treatments for SIBO. And so those are references, and that's the end of our presentation. Do you guys have any questions?
Y'all gonna let him go with no questions? It's impressive. I will state most of you all are muted, however, so if you have questions and you're muted, you might need to unmute yourself.
I just have a quick comment. If I ever got this, how am I supposed to cook without garlic, onions, or celery?
I've got nothing for that because that would be my complaint as well, Judy. And not gonna lie, that would very much so be my complaint as well. Because I'm like, that's I live with those things. So, does anyone else have a question?
Hi, I have SIBO, and just to address it, it's very difficult to prepare meals without onions and garlic, or to purchase, say, spaghetti sauce. But if you can avoid onions and garlic, those are the main problems I find with SIBO. It's not fun.
I can imagine it is not.
And I would want to say that typically SIBO shouldn't be a long-term disease. So technically, the alterations of food won't be forever. It's just so that the SIBO can be basically not cured, but like under control. And then you can start reintroducing those foods. It wouldn't be for a change of diet forever. It was just so that you can help clear the SIBO.
What is the likelihood, not with you saying that, okay, it's not long-term, what is the likelihood of it recurring? You know, kind of like kids who get recurring ear infections type thing.
Yeah, so I have read other studies that said that it is very easy to reoccur after you get it for the first time, especially as you get older as well, just because the slower gut motility as you get older. However, there isn't a lot of research about what to do about that. And of course, like we don't want to reuse antibiotics that you've used before. So, and that's why I said it's still very under-researched. So we are not sure, which is why diet kind of plays a big part in it for now.
And I just thought of one other thing, John, what is the risk of using the antibiotic and killing off the good flora in your gut?
Yeah, so there is a risk for that. However, with the overgrowth and antibiotics typically not being used for more than 14 days, if you use it properly, it shouldn't destroy the good gut bacteria.
Nan, you have a question in chat and they just want to know if the breath tests available are available over the counter or only through your primary care provider.
So right now I believe that it's only available through your primary care provider. Just because I believe it's very no, I think that's it. It's just right now it's just as through your primary care provider.
Yes, Pam, I looked for your email address because I know that you have chimed in for other in-services and I couldn't find it. If you put your email in chat, I'll email it to you. Are there any other questions for Nan? Hearing none.
I have one. What if you, so I heard about celiac disease. What if you have non-celiac gluten sensitivity?
Sorry, could you repeat the question?
So I heard you say that celiac is a risk factor. What about non-celiac gluten sensitivity?
So, in SIBO, gluten can also exacerbate SIBO symptoms. So I'm sorry, I'm struggling to understand the question exactly. Are you asking if you have the non-celiac gluten, I forgot how you put it, sensitivity, will it still exacerbate SIBO? Is that correct?
Exactly, that's right.
Yes. So yes, gluten, I believe is also considered one of the complex carbohydrates. So that will also exacerbate the SIBO.
Okay, thank you.
Mm-hmm.
Excellent. Now, are there any more questions? Then I'm gonna let Nan go. So thank you very much, Nan.